Today, we will be reporting on all things related to comas. First, let's discuss the case of Karen Kinlan. In 1975, a 21-year-old Karen Ann Kinlan suffered cardiopulmonary arrest after ingesting a combination of alcohol and drugs. She subsequently went into a persistent vegetative state. She was described to no longer having cognitive function, but retaining the capacity to maintain the vegetative parts of neurological function. She grimaced, made chewing movements, uttered sounds, and maintained a normal blood pressure, but was entirely unaware of anyone or anything. She had been on a respirator since her admission to the hospital. Kinlan's parents asked that her respirator be removed and she be allowed to die. Kinlan's doctor refused, claiming that his patient did not meet the legal definitions of brain death. Kinlan's father, Joseph Kinlan, went to court to seek appointment as his daughter's guardian and to gain the power to authorize the discontinuance of all extraordinary procedures for sustaining Kinlan's vital processes. The court denied both of his petition. Joseph Kinlan appealed to the Supreme Court of New Jersey. He requested to have Kinlan's life support removed based on the U.S. Constitution's First Amendment, the right to religious freedom. The court rejected his request, but stated, however, that an individual's right to privacy was most relevant to the case, and this included a patient's right to refuse treatment in some situations. The New Jersey Supreme Court ruled that Karen's right to privacy may be asserted on her behalf by her guardian under the peculiar circumstances here present, and that if Karen were herself miraculously lucid for an interval and perceptive of her irreversible condition, she could effectively decide upon the discontinuance of the life support apparatus, even if it meant the prospect of natural death. Balanced against Kinlan's constitutional right to privacy was the state's interest in preserving life. In many cases, the court had ordered medical treatment continued because the minimal bodily invasion resulted in recovery. In Kinlan's case, bodily invasion was far greater than minimal, consisting of 24-hour nursing care, antibiotics, respirator, catheter, and feeding tube. According to Judge Hughes, we think that the state's interest weakens and the individual's right to privacy grows as the degree of bodily invasion increases and the prognosis dims. Ultimately, there comes a point at which the individual's rights overcomes the state's interest. Kinlan's physician had refused to remove the respirator because they did not want to violate the prevailing medical standard and practices. The threat of legal ramifications strongly influenced the existing medical standards and practices of healthcare providers. The court observed that life prolongation advances has rendered the existing medical standards unclear, leaving doctors in a quandary. The court suggested that respirators could be considered ordinary care for a curable patient, but extraordinary care for irreversibly unconscious patients. It was also suggested that hospitals form ethics committees to assist physicians with difficult cases like Kinlan's. The state promised to prosecute anyone who terminated Kinlan's life support because such an act would be considered homicide. The New Jersey Supreme Court, however, rejected this consequence because the resulting death would be from natural causes. In March 1976, the New Jersey Supreme Court ruled that if the Hospital Ethics Committee agreed that Kinlan would not recover from irreversible coma, her respirator could be removed. All parties involved would be legally immune from criminal and civil prosecution. After Kinlan's respirator was removed, she continued to breathe on her own and remained in a persistent vegetative state until she died of multiple infections. Now let's talk about the standards of brain death. According to the international guidelines, brain death is defined as a diagnosis and confirmation of death based on the irreversible cessation of functioning of the entire brain, including the brainstem. 3 essential findings in brain death are coma, absence of brainstem reflexes, and apnea. The medical criteria for brain death, according to the Harvard report, includes unreceptivity and unresponsibility, no movements or breathing, no reflexes, and a flat EEG. On the other hand, the Philadelphia Protocol establishes irreversible coma as a lack of responsiveness to internal and external environment, absence of spontaneous breathing movement for 3 minutes in the absence of hypocarbia and while breathing room air, no muscular movements with generalized flaccidity, and no evidence of postural activity or shivering. reflexes and responses, falling arterial pressure without support by drugs and other means, and an isoelectric EEG, recorded spontaneously and during auditory and tactile stimulation. These criteria shall be present for at least 2 hours, and that the death should be certified by 2 physicians other than the physician of the potential organ recipient. According to the legal criteria, brain death can be classified when 2 physicians, who should preferably be, but not necessarily limited to, a neurologist, neurosurgeon, internist, or anesthesiologist, shall determine and establish brain death based on existing guidelines. A second evaluation by the same 2 physicians must be performed after an interval of at least 4 hours. If the findings remain unchanged and brain death is confirmed, a declaration of brain death shall be signed by these 2 physicians. A death certificate shall then be signed by the attending physician. The date and time of death is recorded on the death certificate and in the patient's chart. The time that the second declaration is made shall be the time of death. The PTC and the AP shall then inform the family that brain death has been confirmed. There are a number of ethical issues surrounding brain death. Confirmation of brain death makes it obligatory for clinicians to cease all treatment, but this raises certain questions. What if the family refuses to accept the diagnosis? Should we refuse to treat further? What if we have another alive but critically ill patient who needs the intensive care bed or the ventilator? To who do we owe our greatest responsibility? The dead patient, the grieving family, or the living critically ill patient who shall die if he does not get care? What do we do when brain death is determined in a pregnant woman but whose fetus is still having a heartbeat? Do we cease treatment, or do we continue to maintain ventilation in this dead patient until the fetus is viable? We also have to contend with ethical issues surrounding harvesting of organs from a brain-dead patient to extend the life of others. Again, to whom do we owe greater responsibility? The brain-dead patient, the grieving family, or the patient in desperate need of that organ? There is no simple answer to the questions stated above. A clinician confronted with a family that refuses to accept the diagnosis should avoid a confrontational approach with the grieving family members. The diagnosis of brain death should be explained by the physician in charge and not by other members of the medical team, to avoid sending mixed messages to the family, since medical personnel use different terms and analogies. The discussion should take place in a formal meeting with all concerned family members and not just a hurried bedside explanation. Time should be given to the family members to ask questions, and the physician should attempt to answer all of these. The family should be given time to accept the diagnosis and should also have an option of getting second opinion from another physician, preferably a skilled neurosurgeon. The physician in charge should remain supportive to the family throughout the process. What religious issues come up in dealing with a brain-dead patient? The challenge for health professionals is in understanding that patients often turn to their religious and spiritual beliefs when making medical decisions. Many patients' anxieties are reduced when they turn to their faith during healthcare challenges. Knowledge of these religious beliefs can affect patient-provider communication, resulting in more culturally sensitive care and improved quality of treatment and outcomes. Different religions have different beliefs on dealing with a comatose patient. For Christians, burial is a family decision. Euthanasia is not allowed, and they rarely donate organs. For Mormons, all individuals will be resurrected and attain a degree of glory in heaven for acts during their mortality. Thus, autopsy and organ donation are permitted. Euthanasia, however, is not allowed, believing that taking the life of another violated God's commandments and His plan for each person. It promotes dignified death, if inevitable. For Islam, autopsy is only conducted for legal or medical reasons. Confession of sins and begging forgiveness may occur before death. Death in general is Allah's plan. Euthanasia is prohibited. Organ donation, however, is acceptable. Do not resuscitate orders are acceptable. There is life after death. End-of-life suffering is seen as a way to purify previous sins so that by the time you meet Allah, you do so in a more pure state. For Protestants, autopsy and organ donation are acceptable. However, euthanasia is generally not acceptable. For Seventh-day Adventists, autopsy and organ donation are acceptable. Death is a state of unconsciousness with a return to consciousness with Second Advent or the coming of Christ. Euthanasia is not practiced. The Church states that patients are not obligated to accept medical interventions whose burdens outweigh the probable benefits. For Roman Catholics, do not resuscitate orders, autopsy, and organ donations are acceptable. There is life after death. Persons approaching death are encouraged to compare their suffering to that of Christ. Sacrament of the anointing of the sick is very important for the seriously ill. Euthanasia is not acceptable because the Church teaches that life should be not prematurely shortened because it is a gift from God. A suffering patient should be offered the respect of deciding where he or she would like to die, but not how, as it interferes with God's preordained plan for each person. Here is a tabular form for some of the religions mentioned earlier. Next, let's discuss the case of Nancy Cruzan. A 25-year-old accident victim suffered lack of oxygen to her brain for 6 to 20 minutes. She was in a persistently comatose and vegetative state, sustained by a gastrostomy feeding tube, although her respiration and circulation were normal. She was oblivious to her surroundings, except for reflexive grimace-like responses to sound or pain. The patient was in a state of progressive spastic quadriplegia with irreversibly contracted extremities. The opinion of medical professionals was that she could live 30 years. She laid in a Missouri State Hospital at the state's expense. Before the injury, Nancy Cruzan had been a vivacious, active, outgoing, and independent person. She had expressed in a very serious conversation with a friend the feeling that she would not wish to continue living if she couldn't be halfway normal and do things for herself. Many other statements to family members suggested that she would not want to continue her present existence without hope as it is. She remarked upon the stillborn death of a niece as perhaps part of a greater plan, so as not to have to face a possible life of mere existence. Commenting on the death of her grandmother after a long illness, she said it was better for her grandmother not to be kind of brought back and forth by treatment. Her parents, acting as guardians, requested discontinuation of the feeding tube. Officials of the state hospital declined, absent a court order. The parents initiated a suit, seeking declaratory judgment sanctioning discontinuation of the feeding tube. After the hearing, the U.S. Supreme Court entered finding that Ms. Cruzan would not wish to continue with nutrition and hydration. It concluded that no state interest outweighed her right to liberty, and that denial of her wish constituted unequal protection of the law. Discussion of the previous cases mentioned ordinary and extraordinary treatment. Ordinary treatment entails reasonable hope of benefit or success. It is not overly burdensome. It does not present an excessive risk. It is financially manageable. It is proportionate to the state of the patient. And, when all things considered, it produces more good than harm. In essence, it is ethically indicated. Elements of ordinary treatment include reasonable or proportionate hope of benefit or success, common diligence, proportionate physical, social, or financial means, and is not unreasonably demanding. In sum, it is what is reasonable. Extraordinary treatment, on the other hand, entails no reasonable hope of benefit or success, overly burdensome, with excessive risk, is not financially manageable, there is no obligation to use it, or is morally optional. When all things are considered, it produces more evil than good. While it might help the patient, the odds are poor, or the risks and burdens are very high. Elements of extraordinary treatment include certain impossibility, whether physical or moral, entailing greater effort, which can be defined as excessive, pain, exquisite and extraordinarily expensive, with severe dread or revulsion. In sum, it is what is inappropriate. Here is a tabular form of what constitutes ordinary versus extraordinary treatment. Please read through it. What do Catholic teachings have to say on ordinary and extraordinary treatments? Natural law and Fifth Commandment requires that all ordinary means be used to preserve life, such as food, water, exercise, and medical care. However, Catholic theologians have recognized that human beings are not morally obligated to undergo every possible treatment to save their lives, even very ordinary ones. Treatments that are unduly burdensome or sorrowful to a particular patient that is beyond the economic means of the person, or which only prolong the suffering of a dying person, become morally extraordinary for that person, even if it is medically ordinary or common. This raises the question of what constitutes ordinary and extraordinary treatment. Two important considerations are the effectiveness and benefit of the proposed treatment. Effective treatment demonstrably alters the natural history of an illness. Beneficial treatment brings some good to the patient, not only in medical benefit, but also in terms of quality of life. Treatment may be effective but not beneficial by simply prolonging the life of a patient. The key word here is to the benefit of the patient. Ordinary treatment offers a reasonable hope of benefit for the patient, while extraordinary treatment does not offer a reasonable hope of benefit. How is this related to the Karen Kinlan case? Kinlan's physicians had refused to remove the respirator because they did not want to violate the prevailing medical standards and practices. Even though Kinlan's physicians assured the court that the possibility of lawsuits and criminal sanctions did not influence their decision in this specific case, the court believed that the threat of legal ramifications strongly influenced the existing medical standards and practices of healthcare providers. The court also observed that life prolongation advances had rendered the existing medical standards ambiguous, leaving doctors in a quandary. Moreover, modern devices used for prolonging life, such as respirators, had confused the issue of ordinary versus extraordinary measures. Therefore, the court suggested that respirators could be considered ordinary care for a curable patient, but extraordinary care for an irreversibly unconscious patient.